So I think with respect to the on-time people, I'm going to go ahead and officially get started with this evening's webinar. Welcome everyone who's here with us in this virtual world that we inhabit a lot of the time these days. We're in a webinar format, so we can't see all of you, sadly, but you have the Q&A, question and answer, to ask any questions or make any comments, and we will try to leave time at the end to get to as many of those as we can get to. I'm Debbie Homolsky, and I have the honor to moderate and spend time with you tonight. I am a retired oncology nurse who spent my last 20 years or so of time in the breast care center, currently doing a support group for young women with breast cancer and occasional other projects like putting together these educational seminars. And with us tonight, lucky for us, is my friend and colleague, Dr. Mindy Goldman, who you can see on screen with me. Dr. Mindy Goldman is a gynecologist and a pioneer, and I love the pioneer part. She's a professor at UCSF and director of the Gynecology Center for Cancer Survivors and At-Risk Women. She's been at UCSF since the early 90s, after completing her OBGYN residency at UCSF. And during this time, she's really pioneered this whole new area of specialization, which is looking at the coordinated women's health issues that people have when they're going through cancer treatment. So we look forward to spending this time with you. Dr. Mindy Goldman, welcome. I'm going to be in the background and I will be looking at your questions and answers in the Q&A, and we will come back to those at the end. So welcome, sit back, and enjoy this conversation with us.
Okay, thank you, Debbie, for that lovely introduction. I am going to share my screen. Welcome everybody. Let's see. Just give me a moment. There we go. And I'm hoping people can see my screen okay. As Debbie said, my main focus is, I like to think of it as sort of bridging gynecology and breast oncology. And a lot of what I do in my practice is helping breast cancer survivors deal with a lot of the menopausal symptoms related to treatment, as well as sexual dysfunction. Just some disclosures about this. So the information that I'm presenting tonight applies to research that has been done related to cisgender female patients. And in many of my slides, I will be using the term women, she, her, hers. And less is really known for trans and gender non-conforming individuals. I'm lucky to be part of the survivorship panel for the National Comprehensive Cancer Network, the NCCN. And in many of our survivorship guidelines, and specifically in our survivorship guideline that relates to hormone-related symptoms, we state that these guidelines pertain to cisgender survivors based on the availability of data in that population, but that the information presented should be followed for transgender survivors as applicable with the appropriate healthcare specialists involved. And the NCCN is actually working to develop specific survivorship guidelines for trans and gender nonconforming individuals. So there's lots of GYN management issues related to cancer. And these are all things that I deal with every day in my practice. The ones that are highlighted in blue, I'm going to be focusing on today, but chemotherapy-induced menopause, fertility preservation, safety of pregnancy after breast cancer, contraceptive management, follow-up for tamoxifen complication, how do we manage menopausal symptoms, treatment of aromatase inhibitor-induced vaginal dryness, indications for removing ovaries in the setting of breast cancer, and treatment options for sexual dysfunction and specifically low libido. And I'm happy after the talk to answer questions related to any of these issues if you have. So one of the things to realize when it comes to menopause is that oftentimes menopausal symptoms like hot flashes are more severe in cancer survivors. And why is that? Well, sometimes surgical treatments of breast cancer may also include removing ovaries. And if that happens, there may be the immediate onset of surgical menopause, meaning if someone had completely normal ovarian function and have their ovaries out, they're going to have immediate surgical menopause with more severe symptoms. Also, premenopausal women who had normal menstrual functioning prior to chemotherapy can have ovarian shutdown with chemotherapy, and the symptoms may be more severe. For women who are postmenopausal and they are using menopausal hormone therapy to treat symptoms, even though there's no data that says that they need to abruptly stop their hormones when they're diagnosed with breast cancer, most people do, and the symptoms may be severe. And then we know that 2/3 of breast cancers are sensitive to hormones, meaning hormonal therapies will be used as part of their treatment. And those include tamoxifen and aromatase inhibitors. And those can sometimes cause hot flashes that are pretty severe. One of the questions that comes up about chemotherapy-induced menopause is it permanent or not? And basically how I counsel patients is it sort of depends on the age of the patient and how much chemotherapy that they get. We know for individuals that are greater than 40 who get the types of chemotherapy agents that we tend to use for breast cancer, that most often upwards of 70% or more of individuals will have permanent ovarian failure post-chemotherapy. It's important to realize, though, that you can see periods return even far out from when chemotherapy is finished, even 2 years or even more. Although most people, if they are going to get return of menstrual functioning, it is most often in the first year. It's important to realize that getting menses back after chemotherapy does not necessarily correlate with fertility and the ability to get pregnant. And we know that even when women do get their periods back after chemotherapy, they are still at increased risk for having permanent menopause, meaning we know that the chemotherapy agents have long-lasting effects on the ovaries. So the average age of menopause is 51. And for people who get chemotherapy, oftentimes they will have menopause much earlier than the average age. Can you prevent chemotherapy-induced menopause? Well, there are actually studies looking at this where they use ovarian suppression agents that are called these GnRH analogs. So those are drugs like Lupron and Zoladex. So they shut the ovaries down. And studies have looked at shutting the ovaries down along with chemotherapy in order to put the ovaries into a resting state and seeing whether in doing so that preserves ovarian function, meaning allows women to get their cycles back sooner, whether it improves fertility outcomes, and it's also been looked at as to whether it improves cancer outcomes. And the largest study was this meta-analysis that looked at 873 patients from 5 major trials, and they showed that when they did ovarian suppression with these GnRH analogs, there was greater return to menses as well as improved fertility. and there was no difference in cancer outcomes. And so many times, the oncologists are recommending ovarian suppression along with chemotherapy in hopes of preserving menstrual functioning. Now, given all of this menopause and more severe symptoms, one of the questions comes up, how do you treat the symptoms? So we know in the general population, the most effective treatment is using hormones like estrogen and progesterone. But those drugs are contraindicated in the setting of breast cancer. And one of the takeaways that I would love for you to get tonight is to realize that there are many alternatives to hormones that can effectively treat hot flashes. They may not be as good as hormones, but they can really alleviate symptoms for many, many individuals. There are low doses of a number of different drugs, antidepressants. They have studied venlafaxine. The trade name of that is Effexor, paroxetine, fluoxetine, citalopram, escitalopram, and desvenlafaxine. Those are drugs like Effexor, Paxil, Prozac, Celexa. They've looked at the antihypertensive clonidine, the anticonvulsant and neuropathic pain medication reliever gabapentin and pregabalin, anticholinergic drugs called oxybutynin. This is used for treating overactive bladder. There are studies looking at soy supplements, herbal products, integrative therapies. I want to focus on some of these these alternative to hormones in terms of prescription alternatives. And two of the best well-studied drugs for hot flashes are venlafaxine and gabapentin. So venlafaxine or Effexor is typically used for depression. And when our colleagues in the psychiatry world use it for depression, they go up as high as 375 milligrams a day. The most effective treatment for hot flashes is 75 milligrams. And the drug actually comes as low as 25 milligram, and you can cut that in half. There are long-acting formulations of 37.5 and 75. So typically what I do in these situations is I start people low at 25. I may cut that in half and start them at 12 and a half. And I work their way up as needed, knowing that the most effective dose is 75 milligrams. It's important to realize that when people are on this drug, it is not working as an antidepressant. So if someone has depression, these doses would not be an effective treatment. Another drug that's been used is gabapentin. Gabapentin is often used in our breast patients when they have chest wall pain after mastectomies, and they get sort of this shooting nerve pain along the chest wall, and gabapentin in high doses can help alleviate some of that neuropathic pain related to that chest wall pain. In low doses, it can help with hot flashes. So for neuropathic pain, sometimes we'll go up as high as 2,000, 3,000 milligrams a day. For hot flashes, the most effective dose is 900 milligrams, and we tend to start at 100 or 300. Now, this drug, none of these alternatives to hormones are more effective than any of the others, but gabapentin is the one that can cause some sedation as a side effect. So if I have someone who says that their hot flashes are occurring more often at night and disrupting their sleep, I would be more apt to use gabapentin so I can take advantage of that sedating side effect. And so if I'm using that at night, I will start at 100 or 300 at night, working the way up to a max of 900 milligrams. If someone doesn't get too sedated, I may give them 300 or 600 at night, and then 100 or 200 during the day as needed. Now, one of the things that, as I mentioned, none of these drugs are any better than any of the others. It's sort of interesting that all these diverse drugs actually help out with hot flashes. And the only thing that all these drugs have in common is that they cross the blood-brain barrier. So we don't know exactly what causes a hot flash, but we think there may be this thermoregulatory center in the brain, and any drug that works centrally in the brain may help out in modifying hot flashes. All of these drugs that I mentioned, that I showed on that first slide, they're all off-label use. The only one that is not is a brilliant marketing ploy. It is low-dose paroxetine. So most people have heard of paroxetine because it is Paxil, and it's an antidepressant. Well, the lowest dose for Paxil when it's used for depression is 10 milligrams. And researchers studied a 7.5 milligram dosing for hot flashes, found it effective, got it through the FDA, but because it's a lower dose than what comes for treating depression, they went and changed the name so that women don't have to think that they are on an antidepressant. So the trade name for this low dose is called Brisdil. It is FDA approved. If for some women, if it requires insurance coverage for them to have an FDA approved drug, I may use it. But other than that, it's not thought to be more effective than any of the others. And I would say in general, we probably have some of the best data for venlafaxine or Effexor and gabapentin. I also recommend taking advantage of the side effects. As I mentioned, with gabapentin, it causes sedation. So if people need, if they're having more of their hot flashes at night, I'm going to use that first line. If I have a patient who happens to have hot flashes and they also have a lot of bladder symptoms like urgency or frequency, I might use oxybutynin because in the typical doses, that's used for overactive bladder, which can cause urgency and frequency. And so I might take advantage of the side effects of that. For any of these drugs, we start with the lowest dose possible. It's important for the drugs that are in the antidepressant category. When they're used for depression, we know it can take as long as 6 weeks to see beneficial effects. When you're talking about using these for hot flashes, you'll see beneficial effects in days. And in general, I try not to mix and match many of these drugs because all of these drugs, again, act centrally in the brain. And anytime you mix and match, you may have sort of side effects like more sedation. There can be any sort of side effects with any drug that acts centrally in the brain, headaches, lightheaded, dizziness. So the more you mix and match, the more likely you are to get side effects. Although there are some times where I may do low doses of gabapentin at night and venlafaxine during the day. I want to talk about remembering to use lifestyle interventions, wearing loose layered clothing, stopping smoking, avoiding caffeine, alcohol. We definitely recommend people avoiding alcohol who have breast cancer anyways, because we know that alcohol, women who don't drink have lower risks of recurrence compared to women who do drink. From the NCCN, the recommendations are no more than 3 drinks in a week, but we know that things like alcohol can also stimulate hot flashes. Avoiding spicy foods. So sometimes when people are able to identify what their triggers are, they can then avoid them. Fans or lowering room temperature, opening the window, exercising regularly, although not too late at night. Sometimes realizing when you exercise, that can actually raise your body temperature. And so exercising regularly, but not right before bed, because that may worsen nighttime hot flashes. Trying to do things to reduce stress, yoga, mindfulness. The theory is that you're narrowing this thermoregulatory zone. And I think this works well for mild hot flashes. I do want to mention a little bit about some of the alternatives, because people will ask about things like herbal therapies like black cohosh. I really mention mostly the drug therapies because I think we have the best data when it comes to the non-prescription alternatives. With some of the herbal therapies like black cohosh, Although there are limited trials that have shown a benefit, there really is also limited trials that show safety in our breast cancer survivors. So through the NCCN, we have said that people should be cautious when using some of the herbal therapies. Certainly with all of the lifestyle interventions, I include in there integrative therapies like acupuncture, like yoga, hypnosis, cognitive behavioral therapies, and there are small trials showing benefits for many of those things. Moving on to some of the cancer treatments and sexual side effects. Realizing that so many of cancer treatments affect sexual functioning. We know that cancer surgeries can cause pain and affect body image and how people feel. Radiation can affect scarring, pain, can cause decrease in lubrication. We see that a lot in our gynecology cancer survivors who've had radiation in the pelvis. We know with chemotherapy that individuals can get neuropathy that can cause decreased sensation and impaired arousal. Also, chemotherapy-induced menopause can cause hot flashes that can affect sexual functioning, can lead to vaginal dryness. Hormonal therapies with drugs like the aromatase inhibitors can cause marked estrogen deprivation that lead to dryness, vaginal pain, and decreased desire. We know that cancer itself can cause pain that can affect sexual functioning. And then certainly cancer-related stress and anxiety can affect desire, can cause orgasm difficulties, sleep difficulties. Other factors, hair loss, weight gain, surgical scars can all affect people's sexual identity. Cancer-related fatigue, sleep dysfunction is really common in our cancer, in so many of our cancer survivors. Emotional responses, in addition to anxiety, fear, sadness, and depression, feelings of betrayal by your body, and then certainly nowadays with isolation related to COVID. So many different things can affect sexual desire. In breast cancer survivors, we see some of the most common sexual side effects are associated with individuals who are on aromatase inhibitors. So I want to talk a little bit about how aromatase inhibitors work and why we see so much sexual dysfunction. So as I mentioned, 2/3 of breast cancers are sensitive to hormones. That means that hormonal therapies will be used to modify the tumor environment. And those hormonal therapies are typically either tamoxifen or aromatase inhibitors. And tamoxifen works as a breast cancer drug by competing with estrogen at the breast receptor binding site and prevents breast cell receptor activation. So it's an anti-estrogen at the level of the breast. Aromatase inhibitors work by preventing the action of an enzyme called aromatase. So enzymes convert one substance to another substance, and aromatase functions to convert male hormones that all women have, called androstenedione and testosterone, into weak estrogens. Aromatase is present in many cells of the body, fat, muscle, brain, breast, ovary, all over the place. And when you take an aromatase inhibitor, you shut down the reaction of aromatase and you shut down all peripheral conversion of estrogen in the body. You cannot use these drugs in premenopausal women because if you block aromatase in the ovaries and the ovaries are working, the ovaries send signals back to the brain, and the brain responds by putting out signals that cause the follicles in the ovary to grow and produce the strong form of estrogen, which is estradiol. And these drugs actually work as a fertility drug in premenopausal women. So if you're going to use it as a cancer drug, you have to shut the ovaries down. If you think about it, when women are taking aromatase inhibitors, they are more shut down than menopause. So with menopause, the ovaries stop producing estradiol, but all this weak peripheral estrogen is being made, and that's shut down with aromatase inhibitors. And so all estrogen production is inhibited. The vagina and outside vulvar tissue is incredibly estrogen sensitive. So there are estrogen receptors throughout the vulva and throughout the vagina, as well as bladder. And so the symptoms on aromatase inhibitors can be pretty marked and much more severe than you even see in menopause. So in some people, they may come in and say, I have a little bit of discomfort if I have penetration. There are other people that will say, I'm sitting and my vagina feels like sandpaper. This is a big, big problem affecting people's quality of life. So what do? I always tell people, fix the things that you can fix. So the first thing is try and manage all of the dryness. First line therapy from the NCCN, the National Comprehensive Cancer Network, says use over-the-counter things. And there are many over-the-counter options that can be helpful. So people confuse sometimes the difference between a moisturizer and a lube. A lubricant is used for sexual activity, mainly to decrease pain associated with friction. A moisturizer retains water and provides longer-term relief and is recommended to be used on a regular basis, more like 2 to 3 times a week. Oils penetrate thin tissue and can be very soothing. I recommend oils to the outside vulvar tissue. It penetrates thin tissue. It can help prevent tears. And inside the vagina is not a sterile area, and people can make coconut oil suppositories where they warm up coconut oil, put it into mini ice cube trays and freeze it. And at night before bed, pop an ice cube and put it as high up in the vaginal vault and let it coat the tissue while you sleep. As awful as it sounds to put an ice cube in the vagina, when the tissue's really shut down, that coolness can actually be soothing. Topical vitamins, there's over-the-counter products that have vitamin D and botanical oils in them. pH balanced gels with hyaluronic acid. This can also help to prevent overgrowth of things like yeast or bacteria that can cause infections. So the pH balanced gels and there's moisturizers that are also pH balanced can normalize the vaginal pH and help to prevent infections. There are soothing agents for vaginal or vulvar pain. Topical anesthetics for people having penetrative sex. They can use local topical anesthetics like lidocaine, that's over the counter, 10 to 15 minutes prior to penetrative sex, can help out with introital or entry pain and doesn't affect deep sensation inside. Lubricants for sexual activity. I have handouts that I'm happy to share of specific recommendations for certain lubricants. Dilators. These can help in a non-sexual setting to figure out what hurts and what doesn't hurt and allow gentle stretching of the tissue. I tell people who are on an aromatase inhibitor, normally no one thinks about the vagina. But unfortunately, when you are on an aromatase inhibitor, because of how these drugs work, if you want to use the vagina, you have to think about it and work on the tissue regularly. I tell people, try and working on the tissue at least a few times a week. What about vaginal hormones? So the benefit of vaginal hormones are you're targeting the tissue of concern. There's also minimal systemic absorption, so minimal absorption into the bloodstream and fewer adverse effects. So how do hormones come? Primarily, we're talking about estrogens, and estrogens come in a ring, a suppository, and a cream formulation. The creams that are listed on the bottom, estrase and Premarin, generally we recommend avoiding in breast cancer survivors. That is because when you push a bunch of cream up inside the vagina, there's a greater surface area and the potential for absorption into the bloodstream. There have been no studies that have shown increased risks of recurrence, but generally it is recommended to be avoided. We sometimes will have people use it by putting a tiny amount on their finger rubbing into a specific area on the outside, but not putting a bunch of cream into an applicator in the vagina. In limited trials, the ring and the suppository formulations are thought to be safe in breast cancer survivors. And so if people fail over-the-counter therapies, we will recommend some of these vaginal estrogens. A lot of people will come in and ask me, what about things like lasers and energy devices? The one that most people have heard about is called the Mona Lisa. This is a carbon dioxide laser, and it was FDA approved in 2014 for skin resurfacing, not for vaginal dryness, but it's being used off-label for a number of things: vaginal dryness, sexual dysfunction, urinary incontinence, pelvic prolapse, something called rejuvenation or tightening. So there's all these different endpoints, and there have been a number of small studies looking at them. It is thought to cause micro trauma to the tissue, and then you get new connective tissue and blood supply, collagen production. It requires 3 treatments in a physician office. It's being done in gynecologists, dermatologists, and plastic surgeons' offices. It's about $3,000 out of pocket. There's some suggestion that breast cancer survivors on aromatase inhibitors may need more than the 3 treatments, not covered by insurance. The FDA did put out a warning statement for the potential for burns. I have not seen that in studies. There was just a large trial, however, published just this past month that did not show a benefit for what's called the genital urinary syndrome or menopause, particularly meaning vaginal dryness associated with menopause. So not sure what's going to happen after the publication of this trial. There are a number of other types of energy devices. These are some of the names: FemLift, FemTouch, VFit, ThermaV, Diva, VSculpt. Again, none of these are FDA approved specifically for the indication they're being used. Small trials only, significant out-of-pocket costs, and full disclosure that I am a advisor to a small startup that is looking at a handheld ultrasound device to treat dryness in breast cancer survivors, and they're trying to get FDA approval. Okay, that's for dryness. What about specifically for painful sex? There are actually 2 drugs that are FDA approved for painful sex. One is called ospemifene or Osfina, and that was FDA approved in 2013. Interestingly, this drug is in the same category as tamoxifen. So these drugs are what's called these SERMs, selective estrogen receptor modulators, and they act like estrogen in some tissue and unlike estrogen in other tissue. So we already talked about tamoxifen is an anti-estrogen at the level of the breast. Ospemifene acts like estrogen at the level of the vagina. So estrogen is good for the vagina. It's thought to improve blood flow, which improves tone, which improves lubrication. Unfortunately, ospemifene hasn't been well studied in breast cancer survivors. So at least for people with hormone-sensitive breast cancer, it is contraindicated. A newer drug called prasterone, or Intrarosa is the trade name, was FDA approved in 2016. So prasterone is vaginal DHEA. So some people have heard of DHEA as a supplement. It's used for a number of different things. It is also a precursor to testosterone. Prasterone has a targeted response and has minimal blood levels of testosterone, so not associated with significant rises in blood levels of testosterone. There are no trials on safety or efficacy in breast cancer patients on aromatase inhibitors, but it is the only drug that does not have a big black box warning on it that is associated with all other types of hormonal therapies. And a lot of people think that this is a potential drug that can be used for breast cancer survivors on aromatase inhibitors. Again, no clear studies, not something I would recommend first line, but something if someone has failed vaginal estrogen, I will oftentimes talk to their oncologist to see if they would feel comfortable trying progesterone. Now, what about low sex drive? So it's important to treat the dryness first, because if it hurts to be touched or have penetration, that's going to affect sex drive. Once dryness and pain is addressed, then you can assess, does someone have a separate issue related to low sexual desire? So a lot of people will ask, what about testosterone in sexual functioning? So in non-cancer patients, there are several randomized trials that have shown an improvement in sexual functioning with these testosterone patches in postmenopausal women with low desire. Despite those trials, their testosterone is not FDA approved for women. And so when it is used for women, it's either compounded from a compounding pharmacy, or people can use a small percentage of male dosing. So usually 1/10 of testosterone doses that are used for men. We know that there are male hormone receptors that are present throughout the vagina and lower urinary tract, and testosterone is thought to work by improving blood flow in that area. The questions are really in terms of safety, and particularly, again, for survivors on aromatase inhibitors. We don't know whether testosterone is safe, and through the NCCN, in our survivorship panel, we say that survivors should use testosterone with caution because we have limited data on safety. It's important to realize, though, there are specific drug options that are FDA approved for low desire. So the first one is flibanserin. The trade name is Addy. And this is a novel, non-hormonal, multifunctional serotonin agonist antagonist. I know that's kind of complicated, but it basically acts within the brain to affect the neurotransmitter levels that are involved in sexual excitement and sexual satisfaction. So it affects dopamine and norepinephrine while decreasing serotonin. This drug was FDA approved in 2015 to treat hypoactive sexual desire disorder, or HSDD, in premenopausal women. It is not FDA. Unfortunately, neither of these drugs are FDA approved in postmenopausal women, but they can be used off-label. There are no specific contraindications that we are aware of for breast cancer survivors, although there is a lack of specific data. I usually, if I'm going to be using these drugs, I will talk to someone's oncologist just to let them know if I am starting them on any drug. Flibanserin is an oral drug. It has to be taken on a daily dosing. Some people don't like that because they don't want to take a drug daily for something that they may not do daily. That's in contrast, and the biggest side effect is that can cause a little bit of sedation. It is recommended that people don't use flibanserin within 2 hours of drinking alcohol because it can cause some additive sedation. The other drug, bremelanotide or Varceli, this was FDA approved more recently in 2019. This one is a little less clear. It stimulates, in terms of how it works, it stimulates the melanocortin receptors and acts centrally in the brain, again, to reduce inhibition and increase excitation. It was also FDA approved for premenopausal women, and it can be used off-label in postmenopausal women, and no specific contraindication in breast cancer survivors. This one is given as a subcutaneous shot that's used 45 minutes prior to anticipated sexual activity. So some people like this because they don't have to take something every day. Other people don't like it because they don't want to give themselves a shot. And the biggest side effect with this is it sometimes can cause a little bit of nausea. Both of these drugs oftentimes have to be obtained from very specific pharmacies in the US. One, I think, may be in Indiana and one in Florida, in order to get special pricing that they will use for postmenopausal women. In terms of prescribing some of these drugs, these are something that I do in my practice. And then one of my colleagues on the faculty, Dr. Tammy Rowan, her specific area of expertise actually is sexual functioning. And both in the general population as well as in cancer survivors. And so she often sees many patients who have low desire and specifically prescribes some of these medications. Other treatments for sexual dysfunction: pelvic floor physical therapy for people that have what's called vaginismus, where there's spasms and it's like the vaginal opening sort of tightens, or other types of sexual pain disorders. Dilators. Dilators can be particularly helpful, as I mentioned before, for people on aromatase inhibitors. We also use it for our other breast cancer, our other cancer survivors, like GYN cancer survivors who's had radiation, or people that have graft versus host disease in the vagina. This allows someone to gently stretch the tissue and figure out what hurts and what doesn't hurt in a non-sexual setting. I'll sometimes recommend something called an O-nut ring. You can see a picture of this here. And those are rings that fit on the base of the penis and can limit the depth of penetration. So if I have a breast cancer survivor who has deep pain with thrusting, that can help out with deep pain. And then certainly a big component of managing sexual dysfunction is seeing specific sex therapists for counseling. And there are people that are nationally recognized as sex therapists that have had education in this area. We have people in the Bay Area that I have worked with that see many of our cancer survivors. I think the biggest thing that I will always say is, again, fix what you can fix or treat what you can treat. I think it's really important to reduce stress and fatigue. It's really important to treat any underlying mood or anxiety disorders. Really important to treat pain. If someone's in pain, that's certainly going to affect their sexual functioning and overall well-being. Treating lymphedema. It's important for us to assess for non-cancer medications that could be affecting someone's symptoms like hot flashes or sexual dysfunction. We see a lot of sexual dysfunction, for example, associated with certain antidepressants. It's important for us to treat sleep issues, treating vaginal dryness, as I mentioned, encouraging regular exercise and healthy diet, and certainly addressing other things like relationship issues. Thanks very much. I purposely wanted to finish early because I wanted to make sure that I can answer any questions that people have. And I'm going to see if I can stop sharing.
I will.
Can you stop me sharing?
I am going to feed you the questions. How about that? And you can stop sharing, I think, from your end if you want to.
Let me just give me a moment to figure out how to do that.
There should be a stop share.
I know. I put why don't you throw me the questions while I keep working on this?
Okay.
Here
there you are.
Yeah.
There you are.
Sorry about that, everyone.
It always takes a minute when you're trying to do it. So there are some wonderful questions from people, and I will begin by asking. Some of them have been touched on a little bit, but maybe you have more commentary. So what's known about the phytoestrogens and herbs like maca and black cohosh? For hormone-dependent breast cancer patients, I was recommended not to use them by my oncologist.
Yeah, I'm sorry, I mentioned that, but didn't put in specific slides. As I mentioned, there is limited data on the safety of both phytoestrogens as well as black cohosh, specifically in breast cancer survivors. We know that for phytoestrogens, if you look at dietary forms of soy, that's actually classified as a heart healthy drug. And many oncologists won't have problems, although won't have concerns, but not all oncologists won't have concerns about people using dietary forms of soy, but that's different than going to a health food store and getting soy phytoestrogens. I would say that in general, if you look at the data on how successful phytoestrogens are in general, it's been mixed, as well as the data on black cohosh has been mixed. In the naturopathic world, I think that a lot of the naturopathic providers use black cohosh. I actually use it in many of my non-cancer patients, but my general take is we don't have enough safety data with regards to either phytoestrogens, black cohosh, or oftentimes other herbal therapies. And my general approach is I will have people talk to their oncologist before recommending that they use any of these products.
And I'd just like to add that possibly the person who's asking this, and also many other people on screen, the difficult task of trying to combine complementary strategies to make it through cancer treatment and feel healthier at the same time. And I would encourage people, especially those of you who are getting your care at UCSF, to really look at the UCSF Osher Center. They have rich resources for people who have specialty knowledge about cancer and connection with the providers in the cancer center, at the same time that they have specialty knowledge about complementary medicine strategies too. And there's a nurse practitioner at the Osher Center by the name of Kathleen Kavanaugh, who does see patients who are going through cancer treatment, as another resource.
I just wanted to add, part of the problem with, I'm a big proponent of integrative therapies, and I would say that the best data for some integrative therapies is actually with CBT, cognitive behavioral therapy. There's also some interesting data about hypnosis, definitely improving sleep quality, which may improve sort of overall well-being, and some hot flashes. Some of the problems with some of the herbal studies and looking at the botanicals is whether you're using the entire root or just a component of an herb. And so a lot of times when you're looking at the results of some of these studies, you're not comparing apples to apples. And that's some of the difficulties. And again, although I have many of my patients using these, I really do think, aside from things like acupuncture, CBT, yoga, hypnosis, I think if you're going to be taking supplements, I really do think you need to talk to your oncologist to see how they feel.
So you mentioned that you have a handout, which we will get from you and share with people who've been on the call. But off the top of your head, do you have any particular brands that you'd recommend for pH balanced gels or topical vitamins? I think you mentioned this a little bit.
So one of the brands I like is that one of my favorite lubricants that I recommend is called Good Clean Love. And Good Clean Love recently came out with a moisturizer. It is pH balanced and it's made with aloe. So the aloe is very soothing and the pH balanced, so it normalizes the pH to an acidic environment, which is what the natural environment of the vagina should be. And it helps decrease overgrowth of yeast or bacteria. One of my favorite suppositories is Female. Female has natural botanical oils and vitamin E in it, and many patients have found that to be soothing. I will pass off my handout that I created. I try to put prices on there because some of these things I think are also really pricey, but there's things with hydrating ovules, there's things with CBD in it, which is thought to have some anti-inflammatory effects. That's a whole other area that I think is really interesting and needs a lot more research about the use of CBD for sexual dysfunction, as well as many things. There are over-the-counter products that actually have very weak forms of estrogen called estriol that are so weak that they're over-the-counter. So there are a number of different products, but by far, I find I probably use most often having people make coconut oil suppositories, Female, and then of the moisturizers, the Good Clean Love is probably my favorite.
And are they accessible online? Do you need a trip to Good Vibrations? What
Yep.
would you do?
So all of the, many of these are accessible in local pharmacies. And if they're not online, you don't need a trip to any of the sex stores.
Okay.
And in fact, when it comes to going to, I think Good Vibrations actually, which is one of the sex stores locally that many of us here have worked with, they are incredibly knowledgeable and have worked with many of our cancer survivors. But when I'm sending people there for things like a dildo, those can be pretty expensive and about $150. When I work with patients and recommend vaginal dilators, the websites that I have on my handout actually have a set of dilators that a set of 6 for $45. They are not natural feeling like the things that you can get in places like Good Vibrations, but they have long handles and they allow people to work their way up with starting with a really small size and working their way up as tolerated to gently stretch the tissue.
So one of our attendees is asking if you're willing to share your slides, if that could go along with the taped viewing.
I'm happy to share my slides, and I think when I do, let me add a few slides on to integrative therapies because I didn't include that, so I'm happy to do that.
Okay, so how would you respond to a woman who has been on aromatase, or the plan is for this woman to be on an aromatase inhibitor for 10 years, and she's asking a question about the return of sexual function. And in this particular setting, although there could be a general response to that, in this particular setting, the person has also had an oophorectomy.
Okay, so first of all, remember when someone has an oophorectomy, that just means surgical menopause. I went into all the depth of how the aromatase inhibitors work because I want people to realize that the symptoms are more severe because when someone is on an aromatase inhibitor, they are more shut down than menopause. All peripheral estrogen is shut down, and the vagina and vulva are very estrogen sensitive. That being said, I don't want people to feel like if you're going to be on these drugs for 10 years, that you cannot have a satisfying sexual life. You do need to work on the tissue. Normally, no one thinks about their vagina. You want to have sex, you have sex. When you are, excuse me, when you are on an aromatase inhibitor, if you want to use the vagina, you have to work on it regularly. So whether that means initially over-the-counter products like these moisturizers, using lubricants, sometimes that means vaginal hormonal therapies, dilators, all of those things. Sorry, when I talk a lot, my throat dries out. My take home that I really try to get across is it does not mean you have to say, I can't have sex for all these years that I'm going to be on these drugs. You can have, it may not be that you feel exactly like you did prior to cancer treatment and prior to surgical menopause and aromatase inhibitor use. But there are plenty of things that you can do that can allow you to have a satisfying sexual life.
Why don't you take another drink? And I'll just make a quick point, which is that being on an aromatase inhibitor over 10 years of time, there's something else that's happening besides the effect of the aromatase inhibitor, which is that you're getting 10 years older. And there are changes that happen with age for most women in terms of sexual desire and sexual activity. So, depending on how old the beginning was and how old the end was, that also has an independent kind of impact.
Yeah, that's a really good point, Debbie. And, we don't have a good sense of sort of what is normative sexual functioning over the lifespan.
Mm.
Most people are comparing what their sexual functioning was like when they were in their 20s or 30s, where most people are more sexually active during those ages. What is important when we're assessing sexual functioning is what you are saying a problem for you in the context of your life or in the context of your relationship? And if that's a problem, then that's a problem that should be addressed. So it's important for us as providers to ask you about this. And I also encourage my patients that, or I encourage all of you who are here tonight, if this is something that is a problem for you, talk to your providers about it. Don't assume that they're going to bring it up, and ask, because there are many things that can be done.
So, what's your sense of timing on intervening with vaginal dryness? Does it help to start early and pay attention and do moisturizers? Or should you wait until a problem declares itself more and then intervene, especially around using any vaginal hormones? How would you see the timing of intervention over time?
Yeah, that's a great question. I actually recommend that people be proactive with the vaginal tissue. And as soon as they get started on aromatase inhibitors, start working on the tissue, regardless if they're feeling symptoms. The more proactive people are, the less of a problem they will have, because then we're playing catch up. That does not mean I would give someone hormonal therapy, because even though we do have limited trials that suggest things like the ring formulation and the suppository formulation of estrogens are safe, it's not something that is recommended as first line. So first line, I would tell people use moisturizers, soothing agents, oils, other things that are on my handout. For people that do things like bike, I'll have barriers to try and help prevent tears with rubbing of the tissue. But the more people are proactive, the less they are to have a problem later on down the line.
And what's your experience with a particular woman over time on continuing on an AI about the progression and the severity of sexual and vaginal symptoms both?
Yeah. I often find that the time when if I have the luxury of seeing people right when they're starting an aromatase inhibitor, I love that, because then I can tell people about being proactive with the tissue.
Mm.
If I don't see them, a common time period where I tend to find people referred to me is usually after they've been on aromatase inhibitor, anywhere between 1 to 2 years, because we do know that some of these vaginal symptoms are more progressive. That doesn't mean that it progresses throughout 10 years of treatment. In my experience, you see it where the symptoms become most severe, usually after a year or two. And they sort of, if someone didn't do any treatment, they sort of stay at that. It's not that they continue to progress during that time. But my take home is really if you're going to be on drugs like this, the more proactive you can be and the sooner you can start working on the tissue, the better.
Great. And what's your, as applied to hot flashes for a minute, the question is, how long do they last? So given that we don't have that answer for a specific person, how would you talk about the spectrum of the length of time that hot flashes last and where you see most of it, you know,
Yeah.
piling up?
So as I mentioned, the symptoms may be more severe in cancer survivors just because of the acute onset from chemotherapy or surgical menopause or side effects. Particularly, we see more hot flashes, interestingly, with tamoxifen than we do with aromatase inhibitors. But just because the symptoms may be more severe does not mean that they last longer. So if you look at women naturally in menopause, about 90% of people will complain of hot flashes in the first year. So the definition of menopause is a year without periods. And in that first year, upwards of 90% of people will oftentimes complain of hot flashes. That does not mean that 90% of people find them so severe that they seek out treatment, but know that it is a very common complaint. If you did nothing and you go to 3 years out, we think that about 85% of women, they tend to get better on their own without treatment. And then there's about 15% of women that the symptoms stay severe enough that they oftentimes seek out medical treatments. And in my experience, the same is often true for my breast cancer survivors, that soon after treatments, whether it's surgical menopause, getting started on tamoxifen, chemotherapy-induced menopause, that most people will have symptoms. I find a lot of my patients will say, I'm going through so much, I'm on so many treatments, I don't want extra medications, even if it's going to help me feel better. And there are a significant number of those patients that over time they get better without them needing to be on medications. And then there are the people who say, you know what, I want to take an extra medication if it's going to make me feel better. And we start them on drugs like gabapentin or venlafaxine or paroxetine or one of these other drugs. What I tend to do is I'll see people every 6 months and sort of check in and see how they're doing. I try to get them on the lowest effective dose so that you minimize side effects. In general, the lower the dose something is, the less likely you are to experience side effects. And so I try to slowly get people on the lowest effective dose. And as they really start coming down on their dosing, I'll then talk to them to say, do you think you're ready to try and wean off of these drugs? Any drug that works centrally in the brain, you don't want a cold turkey. You want to do a slow wean so that you don't have any sort of rebound effects. So hopefully that helps.
Great. Can you use E-string alongside suppositories?
Good question. And the general answer is yes. It can get quite messy because sometimes the E-string will cause a whitish vaginal discharge. Sometimes people will have a discharge with the suppository. Some people find there's only one place that the E-string fits. A lot of people worry about, am I putting it in the right place? It fits behind the pubic bone and it angles down behind the cervix, which is also important because sometimes if women have had a hysterectomy and if they've had a total hysterectomy and they don't have a cervix, sometimes the E-string isn't a good option because it doesn't stay inside. If they can use the E-string, it's a little bit, sometimes it feels a little awkward for some people because when they push the suppository inside, they'll feel the ring, but you don't have to worry that you're putting it in a place where it's going to hurt you or it's not going to be as effective. So you can use some of these things. And it also, I'm not aware of it affecting the integrity of the E-string. The E-string is a silastic ring that has a little, it's called a depot of estrogen, and it releases a low level of estrogen on a daily basis over the course of 3 months.
And then a follow-up question about E-string. What's our current sense of how long people can safely stay on E-string?
Yeah,
question mark indefinitely?
Yeah, that's a really good question. And I have not seen studies that have suggested that there is a limited length of time. There's also, by the way, no studies that say when you're on these treatments that you should be measuring blood levels of estrogen. There is not data that says these treatments increase the risk of recurrence. And in my experience, I have continued people on it long term. What I oftentimes find is people get tired of getting these prescriptions. Also, there's some insurance companies don't always cover them, and they're quite expensive. In fact, I send people sometimes to Canada. I'll give them a written prescription and tell them find a pharmacy in Canada where it's oftentimes cheaper. But in my experience, a lot of people want to take a break after a while. They get tired of putting something in the vagina, and they want to see, how do things feel if they stop using something. They're usually okay for 6, sometimes even 12 months, and then they may have to periodically use it again. So my overall experience is I find people are unlikely to use it for 10 years continuously or more. But I also have not seen data that says it is not safe to use it in that regard.
Mm-hmm. So here's a complex and interesting question that there's not an easy answer to, really, but we could talk about for a long time. Can you talk about the sense of fear and anxiety that comes with menopause, not just with cancer and cancer recurrence, but from all the emotional mood side effects of menopause, whether it's happening normally or induced by hormone therapy?
Oh, that is a really good question and a tough question. So one thing when it comes to mood that I do want to clarify is menopause does not cause mood disorders or depression. It's important to realize that women are 2 times more common than men to have mood disorders, and mood disorders occur more often at certain times in our lives, which is postpartum and around the time of menopause. So certainly there is a hormonal interplay, but it is not thought that hormones cause depression. The way that I think about it is if someone is inherently susceptible to a mood disorder, menopause is a time period when that may occur. There are many people that will get mood changes of menopause, but that doesn't necessarily mean anxiety disorder or depression. Some of the difficulties with our understanding of menopause is everyone goes through the same thing in terms of the ovaries stop producing estrogen. And we know that there are symptoms that are associated with that include hot flashes and night sweats and mood changes and sleep disorder. But everyone's symptoms vary. You can have some women that have very mild symptoms and other people are completely disabled. And so there's a lot of variations in terms of how menopause presents. And I think now there's a lot more research sort of looking at, can we understand the different manifestations of menopause? And maybe there's a lot of other things like the gut microbiome. There's a lot of research going on with that, looking at how other things may affect how menopause manifests. So that I find is an area that we don't understand well, why one person is completely disabled and another person breezes through menopause. The other thing that I always like to talk about is the sleep issues associated with menopause, because there is this common understanding that, well, that must be related to the hot flashes and night sweats. You get hot, it wakes you up out of your sleep, and then your mind starts going and you can't get back to sleep. But there are actually some interesting studies where they brought menopausal women into a sleep lab and they measured their temperature. So we know when women have a hot flash that there's actually a rise in body temperature. So they measured their temperature and then they did these EEG monitoring of their brain. And with that EEG monitoring, they could tell when women get into a deep REM sleep. And what they found was really interesting, which was in the midnight to 2 a.m., women were having hot flash after hot flash that they documented by a rise in body temperature. And during that time, their EEG showed they were not in a deep REM sleep. But in the 4 to 6 a.m. period, for the people who were in a deep REM sleep, they were also documenting hot flash after hot flash, and they didn't wake up. So what it says is, if you're able to get into a deep REM sleep, the hot flashes may not bother you so much. And some of the problem is a sleep dysfunction on its own, that people aren't able to get into that deep REM sleep. And I say all of that complicated stuff to say the sleep dysfunction that's associated with the menopause is a whole other area that we don't have as good a handle on. And this is all general menopausal stuff. And you overlay that with people who are going through all cancer treatments and all of the side effects of all the cancer treatments. And I find that this all gets even much, much more complicated. So I try to tell people, be kind to yourself. Again, fix the things you can fix. I'm constantly talking to people about working on sleep hygiene. I have handouts on sleep hygiene, on timed eating. That's a whole other one where I'll tell people, try to have nothing from dinner till bedtime. You want to have nothing for 3 hours other than water. And I found it's incredibly hard to do. But if you give your body a big caloric load before bed, when your body goes to metabolize that caloric load, it gives off heat. And that can worsen nighttime hot flashes. And it also tends to affect people's sleep. And when you don't do that, your body goes to food stores, your metabolism is slower, and it processes those food stores better than a big caloric load. So I talk to patients all the time about timed eating to help out with sleep dysfunction and help out with nighttime hot flashes and night sweats. So I think there's lots of behavioral things that people can do that can really help address so many of the aspects of menopause.
And I think, the minute you raise questions about all of the emotional changes that happen from partly around menopause, partly around cancer treatment, to remember that there are resources, as you would be going to see a gynecologist about these women's health related issues. You can ask for a referral to psycho-oncology if whatever the source, whatever the complex source, and how much of this is hormonal and how much of this is the cancer diagnosis, different for different people, but that there are resources to take it seriously and get some help if that's what's actually happening for you. Okay. So I think you've addressed this some, but I want to hear if you have anything you want to add. How would you summarize what you think are the most important actions someone should take to care for her vagina in menopause, independent of sexual activity? Just the self-care of that tissue.
So particularly for women who are on aromatase inhibitors, people can experience dryness and irritation and pain that has nothing to do with sexual activity. So some people, when the symptoms are more severe, when they pee and they wipe themselves, it can hurt, or they're sitting or they ride a bike and it can be irritated. So when I talk about being proactive with the tissue, that really is for people, regardless of what their desires are for sexual contact and sexual activity, whether that's self-pleasure or pleasure with a partner. I think it's really, really important for people to understand how those drugs work and to work on the tissue, whether it be with oils or moisturizers or soothing agents, to as soon as people start feeling any sort of irritation. If they haven't been proactive, I certainly have them be aggressive every other day, every third day, as often as they can, working on the tissue. And I also will tell people, don't be surprised, because people will come in thinking, oh my God, there's something wrong because I do have pain, I do have irritation, and I'm not even sexually active. So that these are common and purely a function, at least for women on aromatase inhibitors, most often a function from marked estrogen deprivation. I also want people to realize that you can see these symptoms on tamoxifen. So tamoxifen has both estrogenic and anti-estrogenic features, and people can get dryness even when they're on tamoxifen. The severity isn't typically the same as on aromatase inhibitors, but you can see it. Also, when women are on tamoxifen, oftentimes we see an annoying vaginal discharge, and that can be irritating. So it can cause, general irritation, sometimes itchiness. It's important if someone does have a discharge to come in for an evaluation. So we figure out, is it just the discharge associated with drugs like tamoxifen, or could it be an infection like yeast or like bacteria? We also sometimes see it in our triple negative patients who've been thrown into menopause just from chemotherapy. For those patients, we have a little bit more leeway because we're less concerned about the use of some of the vaginal hormonal therapies. But all of my breast cancer survivors, no matter what type of breast cancer that people have, I really encourage them to try and pay attention to their body, listen to the symptoms that their body is telling them or listen to the symptoms that they have, and try to be proactive and come in for an evaluation if you're not sure of what's going on.
So follow up in the triple negative family for women with triple negative breast cancer. Are there concerns about using estrogenic compounds in the vagina?
Yeah. So when you look at the national guiding organizations when it comes to the use of hormones in triple negative, we know that the highest risk of recurrence is in the first couple years. And just because someone had a triple negative tumor doesn't mean that they couldn't have a recurrence of a hormone positive tumor. So when it comes to systemic hormones like patches or pills, it is contraindicated, certainly for the first 2 years. But if people have had long disease-free intervals of at least 2 years, and I always go by what the oncologists, how comfortable they feel, those are the patients that I will give birth control pills to and hormone replacement therapy to when they've had long disease-free intervals. When it comes to vaginal hormonal therapies, certainly I feel much more at ease of giving any sort of vaginal therapy. I think we have the best data when it comes to cancer survivors with the ring and suppository formulations. So I am more apt to use that in my patients with triple negative disease. But if they dislike those, I would feel more comfortable giving them a cream, because we don't have any studies that says that cream formulations would increase risks of recurrence.
So if you could just characterize what you see as the difference between symptoms experienced after an oophorectomy versus using tamoxifen, Zoladex.
Yeah. So first of all, it's important to realize that using ovarian suppression drugs like Zoladex or Lupron essentially does the same things as an oophorectomy. I see a lot of patients who will come in and say, should I have my ovaries out because I have breast cancer? And how I counsel them if they are on ovarian suppression drugs is, what is the likelihood when you finish your course of hormonal therapy that your ovaries will still have function that could provide you with both quality of life and health benefits? Meaning, no one really likes having induced menopause in terms of the symptoms, but we also know that the estrogen that the ovaries produces protects against heart disease and bone loss. And if the greatest likelihood is when someone finishes their treatment that their ovaries would still be functioning, I will tell them, don't do anything permanent. But if the greatest likelihood is that their ovaries will not have functioning, for example, in someone who maybe was 40 or 42 and they got chemotherapy that we know has long-lasting effects on the ovary, and then they're going to be on hormonal therapies till 47 or 48, that person is not going to have hormonal function when they finish their treatment. And I will oftentimes say to them, rather than getting a shot to keep your ovaries quiet, you can have your ovaries out. Now, it's not that it is more effective. There is controversy as to whether the postmenopausal ovary does anything in terms of like producing male hormones and whether that affects sexual functioning. In the GYN world, we generally feel that for all intensive purposes, that the postmenopausal ovary doesn't do a lot, such that drugs like Zoladex and Lupron effectively do the same thing as oophorectomy. And so that means that those drugs are causing surgical menopause, which is the same thing that women will go through when they hit the natural age of menopause. The symptoms, as I said, may be severe, more severe because of the acute nature of being thrown into menopause, but it's not that they last longer or you have to treat it differently. That's different. And so that applies to women on tamoxifen. That's different. And I know I keep talking about aromatase inhibitors, but that's different because for women on aromatase inhibitors, you are having all peripheral production of estrogen shut down. And so those symptoms tend to be more severe.
So this is actually a whole other topic, but I thought you might head people into the direction of resource around a question, advice that you have for people experiencing incontinence related to menopause and or aging.
Okay. So first of all, there are different types of urinary incontinence. We classically think about stress and urge. So stress incontinence happens when things like coughing, sneezing, laughing, or picking something up. So you do something that increases pressure in the abdomen. That pressure in the abdomen is transmitted to the bladder neck, and there's weakness around the bladder neck, and the bladder neck can't hold, and people leak. The other type of incontinence is urge incontinence, and that tends to be associated with you get the urge to go, and it's so strong you can't make it to the bathroom. Oftentimes, people that have that get up at night to pee. We consider it abnormal if people are getting up more than 2 times at night. There are estrogen receptive tissue around the urethra where people pee from and portions of the bladder. And for mild symptoms of incontinence, sometimes vaginal estrogen may help out. So things like the East ring or the suppository formulations may be helpful. Along with that, for mild incontinence, we oftentimes will refer people to pelvic floor physical therapists. So pelvic floor PT is a subspecialty within PT that are expert physical therapists specifically focused on the pelvic floor. And they work with people who are having pelvic pain, various types of sexual dysfunction, and also urinary incontinence. And there are specific exercises of pelvic floor work that can be done to help out with incontinence. If someone isn't able to isolate their pelvic muscles on their own, a pelvic floor physical therapist will sometimes use electrostimulation of the muscles to show them how to isolate the muscles, and then they'll come up with a specific training program for them. There are also medications that can affect the bladder muscle. I mentioned that one of the drugs that is now used off-label to treat hot flashes as an alternative to hormones is a drug called oxybutynin. The trade name is Ditropan. And that drug is typically used for urge incontinence. So if someone has some urgency or frequency and hot flashes, I might be apt to try that medication. If those things fail, there are actually subspecialists within GYN called urogynecologists. These are people that have done a fellowship in urology and gynecology, and they will specialize in doing more advanced evaluation and treatments for incontinence, which may include surgeries, sometimes bulking agents. They do things like injections of Botox. There are much more in-depth evaluations where they do what's called these urodynamic studies to try and get a sense of what's going on. So there are lots and lots of things that can be done. And so if someone has incontinence, it's also important, talk to your provider. Don't think that that is a natural part of aging. Even though it is more common to see incontinence as women age, that is not something that all menopausal women develop, and there are many things that can be done to treat that.
So what have you seen with this in the case of somebody who has a recurrence down the road and is restarted on hormonal treatment? Do they start all over again with hot flashes? Do you see changes in that? Does it depend on age, etc.?
Yeah, that's a really good question. And I would say, in my experience, it's been really mixed. Because we know that many people who experience menopause naturally have their worst symptoms initially. And then, as I mentioned, by 3 years, they're kind of, they may have a hot flash now and then that's sort of mildly bothersome. In my experience, in my breast cancer patients, oftentimes you see that same thing when they get put onto hormonal therapies for recurrence. That is not always across the board, however. We know, particularly with drugs like tamoxifen, when you look at the side effect profile, one of the most common side effects with tamoxifen is hot flashes. So I know that tamoxifen oftentimes is not used for recurrence. More often, drugs like aromatase inhibitors are. But because any of these drugs modify the tumor, the hormonal environment of the tumor, sometimes you will see recurrence of hot flashes. For those patients, in my experience, they're not as severe as they were the first go around. But we can oftentimes restart someone on a drug. Even if it was a drug that they used years ago, they can try it again. It doesn't mean that it wouldn't be as effective, or we can try many of these other alternative to hormones. That's sort of the biggest thing, is I want people to realize there are so many alternatives to hormones that can be used to modify hot flashes, as well as a number of the integrative therapies that can help to alleviate symptoms too. You definitely shouldn't suffer if you're having hot flashes. At least try and seek out treatment. They're not always effective, but most people, we can take at least the severe symptoms and make them a little less severe.
So a real concrete question for you, and it will, I think, wind up our time together for tonight. But how would you define off-label use? What does that mean?
Yeah, I'm sorry if I didn't make that clear before. So there are drugs that have FDA approved indications. And then there are drugs that are used without having FDA approved indications. And that's what I mean by off-label. So all of these drugs that I talked about that are alternatives to hormones to treat hot flashes, all except low-dose paroxetine are off-label use. They are not FDA approved for that indication, but there are specific guidelines. Actually, through the NCCN, we have guidelines that talk about the dosages that you should start at, the most effective dose that can be used. We also talk about off-label use of drugs like testosterone. As I mentioned, that is not FDA approved for women and is still controversial about the use of that in breast cancer survivors. But because that is not an FDA approved indication for women, whenever we are using testosterone for women, we are using it as an off-label drug.
So we're at the end of our time, but I can't resist just asking you one more question, because it's a question about libido and having joy with sex again. What's been your experience with people in the survivorship world when hormone therapy is all finished? What's your sense of the return of the libido or return of pleasure and enjoyment of having sex?
Um, First of all, before I answer that, I do want to make one comment about libido is I see a lot of people who are coming in on chemotherapy or just finishing chemotherapy complaining of low libido.
Mhm.
And one of the things I try to do is really normalize that. It is really hard to feel sexual when you are in the middle of chemotherapy and you don't feel well. So that is very, very normal response. And in my experience, as people get further out from active treatment and much of their quality of life starts returning, along with that is included in that is sexual functioning. I think that what happens as people go through these years and years and years of hormonal therapy, and as you were mentioning, Debbie, people are aging during that time, and we don't have a good sense of sort of what should be the natural experience, someone's natural sexual experience with aging. What I have found is oftentimes people sort of adapt to what the new normal is. They may sort of wish that their current sexual functioning is what it was, but for many women in menopause, it's not what it was when they were in their 20s or 30s anyways. And I find that for a lot of my breast cancer survivors, they sort of create what their new normal is for so many aspects of their life, and including in their sexual functioning. And I find that most people are able to get to a point where they feel like they can have a satisfying sexual life. May not be exactly what it was like before, but that doesn't mean that they can't have a satisfying sexual life going forward.
So, Dr. Mindy Goldman will see later all of the beautiful gratitude and thank you notes that people have been sending in the chat and in Q&A. And we really do appreciate your being with us tonight. Anybody who registered tonight will receive the slides, will receive a copy of a link to this presentation and the handouts that were referenced about different products that can be helpful. And there are a few remaining questions that I'm so sorry we didn't get to, but we'll try to address that in the email in a way that's generic and hopefully interesting to everybody. And we're going to be building this library over time on different topics. So let us know, let Kaylee know when she emails you if you have things you're interested in and things you want to know more about. And thank you so much for being with us this evening. Good night.